Good evening, everyone. I'm Kaleem Joy, and this is Natural Childbirth 101. I'm a licensed midwife, a certified pediatric massage therapist, and a certified professional midwife. And as we're waiting for everyone to join us, I just want to welcome you if you're joining me live. If you're watching this as a recorded, thank you for coming and watching. Please be sure to take a look at a lot of the other videos that are on various topics about pregnancy, birth, parenting, life, and the list goes on. I want to thank those of you who have given me ideas for lives. I'm always open to those and enjoy knowing what you're interested in and being able to give some insight and understanding to it. So tonight our topic is pregnancy, too much water or too little water, and what all of that means. Yes, thank you. I am definitely feeling better. I still have a in my throat, but that's about it. But thank you so much. All right, so looking at what that is, we're going to start talking about too little water. And when you're pregnant and you're diagnosed with having too little of water, meaning polyhydramnios, that's the big medical term for it, meaning a little bit of water. And it can kind of set a lot of things in motion. One, it usually sets in motion a concern or a worry. With whoever your care providers are, it sets them in motion as to what do they need to do next, and what the causes are, looking for the causes, figuring out if there is a treatment for it, and figuring out what you're going to do next. So one of the things to remember about me is I am a midwife. So that means that I deal with normal. So the amount of times that I have dealt with clinical oligohydramnios, or too little water, or polyhydramnios, which we'll get to in a few minutes, which is too much water, is very minimal. Now there's some reasons why with that, and some of that has to do with the clientele that I have an opportunity to serve with, which means that, like all of you, you're working towards having the healthiest pregnancy. So you pay attention to your diet and the fluids you drink, the things that you do, things that you're exposed to, and you have a tendency to be a healthier population. So that's where midwifery is about dealing with normal, but it's also about assessing when something goes out of normal, and that's what we're talking about tonight, when something goes out of normal. And my goal is, if we feel like something has gone out of normal, can we, with simple measures, bring it back into normal, because it was a simple life, something that we could alter. All right, so talking about too little water, let's define it first. When you look at a clinical term of oligohydramnios, or too little water, it depends on where you are in pregnancy. And generally the number wants to come up to around the 10 mark, all right? When somebody wants to do what's called an amnio fluid index, AFI, that's what they're looking for. They're looking to see how much amniotic fluid is in surrounding your baby. Well, in order to do that, they have to look in 4 different quadrants, or top and 2 bottoms, and they need to look for pockets of water. Those pockets of water cannot contain a cord. So you can see that if somebody is trying to get a pocket of water, but they're having to angle the transducer on the ultrasound machine, or move things, or find where they can be, that doesn't have any cord in it. If your baby happens to have a lot more cord, and that cord is floating, which is what it should be doing, is floating in that beautiful water, they cannot use that water that the cord is floating in order to calculate that into those measurements. So it doesn't mean that all AFIs, measurements of amniotic fluid index, are wrong because that happens. It just means that there can be a lot of variability. So understanding that variability, you would want to be able to advocate with, fine, if it shows that it's low water and it's down around 2 or 3 or 5, and usually a 5% based on the gestational age is what they consider low. So it goes on a graph, a curve. And looking at the amniotic fluid being low, it means that it's around the baby and there's not a lot of fluid around the baby when it really is clinically low fluid. But when the ultrasounds are done, and this is why I want to bring this to you, if this ever occurs for you or it occurs for a family or a friend, is to be able to recognize that the ultrasound itself may be the fallacy, all right? So what do you do if there's low fluid? And how does fluid get made? By the time the baby's at about 20 weeks, the fluid inside is primarily getting made from, yes, the baby peeing, believe it or not. The baby pees, the baby drinks the fluid, the bladder gets full, fluid comes in through the umbilical cord to some extent, and that's how the baby can then fill its bladder and pee, and there's a recycling that goes on. But there's other places that amniotic fluid is made also, and that's in the amniotic sac, which is dependent on the placenta doing its job well. And also babies start to have fetal respiration as they get older, and they actually practice breathe, if you will, and some of the fluid that is created in their lungs actually is fetal breathed out into their amniotic sac. So there's a lot of different things that go into making that fluid. And what I want to encourage you with is, one, the solution, if it is a solution, and understand that if it is the solution, is to hydrate, right? You hydrate by drinking, and you do that for a couple days, and you go back and you have another scan done. Now, two things will happen on that scan. The fluid will increase and be wonderful, and I've seen it go from 3 to 10 in a matter of a few days, because either one, mom was dehydrated, it was a hot weather and part of it was dehydration, or some of it was needing to hydrate and some of it was the scan itself not being able to pick up the pockets that are strictly just fluid with nothing in them. So we have a variability based on technology, and we have the potential that some of it may be that the birth giver, the mom, really does need to hydrate well so that then the baby can rehydrate, so the baby can manufacture that water, and it shows us that the placenta is functioning well. So one of the symptoms of a placenta that may be not functioning as well, it may be getting tired, especially if you're post dates, or for whatever reason, this particular pregnancy, that particular placenta is having a hard time keeping up with the job it needs to do to get all the way to term or past. And so if that happens, the placenta may not be able to give the baby certain things that it needs to hydrate like that to be able to keep that functioning. So that's a symptom, right? Now, obviously, if the placenta is clinically not doing well, then higher scale monitoring and deliveries need to take place. So we go back to the work that I do is working with normal, and when things go out of normal, can we correct them within a short period of time and be able to say, oh, well, all it was hydration, things are working. If it isn't just hydration, then we recommend an ultrasound to find out just how much water is going on in there. Does the placenta look reasonably functioning well? And we do a non-stress test on the baby, which is being able to understand how the baby is able to respond to its environment. Is it getting enough food? Is it getting enough fluids? Is it able to move around? Because low fluid, one of the symptoms, happens to be that you can really feel the baby and not much that the baby is palatable anymore, where you can tell there's not much around that baby. So by palpation, that's one thing that can be a clue. Another is the baby's movements go way down because it strictly just doesn't have any room to kind of move around in there, right? So that can happen. And when these types of things come up, that's where I say drink well. Let's make sure we rest you and see that things go well. And then we see you back, you know, in 3 to 5 days, see what's happened. The other thing that can be a telltale sign is that measurements have gone down, along with feeling like the baby is too easy to feel and there's no palatability, and the movement's gone down. All of those together indicate there's a lower water. So when we see that lower water, we hydrate. Hydrate, 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 and within 3 to 5 days, it's either corrected itself or it hasn't, all right? And so how do you know it's corrected itself? The baby starts moving around. You can ballot the baby back and forth. The baby's movements, obviously, you feel, and things seem to be going better. On an ultrasound, it takes about that, even 24 hours will really hydrate, but I'd give it 2 or 3 days unless there's an urgency someplace that's going on, and then go back for another scan and see what it looks like. Now, here's a little story, all right? Many years ago, we did have a family that we met at their childbirth class. We were asked to come in and just tell them a little bit about midwifery and what we did and etc. And this family had met us. Well, they had the teacher to be their doula. And at that time, she got diagnosed with having low water, so they asked they wanted to induce her. So that's one of the risks of that low water, if it is incorrect versus a correct diagnosis, that they wanted to induce her. So she went into the hospital, they started inducing her. She was on Pitocin for 24 hours without getting much labor started. And at about midnight, we got a phone call. And the phone call was from this teacher, and she said that one of the families in her class that we met wants to have their baby at home. Now, that was a very unusual phone call. And I said, all right, it's midnight. What's going on? She says, well, they've been in the hospital for the day trying to get induced, and the labor hasn't progressed. And the birth giver said to her partner, who was not in favor of a home birth in the beginning, I think we made, the partner said, I think we made the wrong decision. Well, the birth giver said, well, then let's do something different. So long story short was, we were asked to see if we would attend them. Now, that's a very unusual thing when they're already in the hospital being induced, right? So we said, well, are they willing to send you home? Yes, they are. All right, well, if they send you home, then you need to hydrate really, really well, go back and get another AFI, and if the AFI looks good, we will entertain the opportunity to talk to you about having your baby at home. So one, we weren't going to just do it because they wanted it. We weren't going to do it, especially when she'd already had a low AFI, but her AFI went up significantly within 2 days. And she was up somewhere around 12, and there's no polyhydramnios at 12. So it took her another week before she delivered, and she did deliver at home, and she had 3 other babies that were at home after that. So that's just one story, but it is a story that often can be a lot of what I hear. My very first live I did was out on a walk. You can go find it on, I think, Midwives Collective of Sacramento, and I did it on low water and what the sequelae can be to an induction. What does an induction mean, and how does it follow itself down the road all the way to the cesarean and the baby in the NICU. All right, so back to polyhydramnios. So hydration is one of the first things to do. Second, get another ultrasound, make sure that it really is a clinical diagnosis. And sometimes you just have to get second opinions, all right? So, causes of it. We talked about baby not peeing, not being hydrated, the placenta not functioning well, etc. They diagnose it by ultrasound, and we talked about that. Let's see. Causes, all right. So the ultrasound can be incorrect. The other thing is, if there truly is low water or too much water, sometimes it's something that's going on with the baby. Now, I say that carefully because anytime there's ever a concern, there's always the concern that something is going on with the baby. And clinically, if there really is low fluid or too much fluid, and it's not solvable, then there is sometimes something going on with the baby. And if there is, then home birth and midwifery or a birth center isn't an appropriate place to have care anymore. It doesn't mean you can't have supportive care from a midwife, but it means that you need to have a high-risk obstetrician, which is what they're really good at, to monitor you and decide what would be the best care. Now, obviously, they're going to give you what they think is best. Your job, if you should run into this, is to be a good questioner. Question why? How will that benefit me? How will that benefit my baby? If we do make that choice, are there some sequelae to that choice that I need to be aware of that could come up that I may have to make decisions about? So you have to be able to get as many answers as you can in order to make those choices and decisions of what's best for you and the baby. All right. I'm not going to go over the things that could be going on with the baby. Those are all things that you can look up. Usually it has something to do with the kidneys. It can do with other things as well. Post dates, though, has nothing to do technically with the baby, although it can deal with the baby being in long enough that the placenta may be getting tired, and that's why the water level goes down. Now, understand that before you start labor, water starts coming down. So there's a natural occurrence to that, and part of that is allowing the baby to get down into the pelvis more, allow the uterus to get around the baby more, to thicken up a little more so it can get more contractions. It's the same thing that happens when water's been leaking, and that's another possibility sometimes, is that water's been leaking and that's why the fluid's low. So they go through checking all of those different things. So having post dates, that is one of the challenges with it. Now, having low water and having the baby and having labor, whether it starts spontaneously or not, what are the risks of that? Well, the cord needs a little bit of cushion so that the contractions don't push on it too hard, which is why we don't want to let waters go too early, because the baby, both head-wise and compression from the cord and various things like that, and especially if you've been diagnosed with low water, heaven forbid you don't want somebody to let your waters go, right? With one exception. Sometimes, if during a labor that has had this issue going on, and the cord seems to be showing that it's having some compression, and a position change can't seem to solve that, in a hospital setting, they can do what's called an amnio infusion, which is where they put a little tube up inside, and they put more fluid in there to give the baby that space to let the cord be happy and let the birth unfold. This is a good thing to have done sometimes, versus a baby who may have so much stress that you have to run to a cesarean. So it's helpful to be able to do that. Now, I do want to talk about one thing, and that is about babies who might have low fluid, who might also be in, say, a breech presentation. Babies, when they have low fluid and they might not be in the right place to have a vaginal birth with a head down baby, these babies don't have enough space with water and buoyancy to be able to move themselves around, so they can sort of get stuck. And especially if they're in a frank breech where the legs are straight up, a lot of times the back of those little legs just can't bend like they need to be able to mobilize the baby. So there's a couple of things that are going on with that. So the solution is get the water up, and then possibly go for a version if you're far enough into close to term where you can have the baby turned and then have a great birth. All right. We'll talk a little bit more about that when we talk about too much water here in a moment. Okay, let's see. Repeat scan, we got that. On go the glasses. All right, so you want to make sure that if baby is going to end up getting an induction, that their little lungs are ripe enough, and you hope that you're far enough, close enough to term should that occur, that would be a successful induction. But there will be more monitoring, there will be more interventions, and it no longer is what you consider just a normal birth. And if you're planning a home birth or you're planning a birth center birth and you're working with a midwife and something like this comes up, it really just goes through your head, because it's not your plans, it's not what you wanted, and that's a really hard thing to sort of bite off and understand. So know that you can do everything possible, including there are homeopathics that sometimes can help with this, believe it or not. And being able to do what you can, and then keep being a good advocate and planning within the scope of what you may have to deal with to have the best birth possible, and make the choices that you can make in a birth that might have to be medicalized with interventions, okay? All right, let me see. I had a couple of little comments and questions come up. Let me go back here for a sec. All right. 35 weeks pregnant, ultrasound confirmed placenta moved away from the cervix. Woohoo! Congratulations! I have a little higher water than normal and am go for a home birth. Oh, lots of baby movement. I'm so happy for you. Congratulations. That's wonderful news. Your baby's just doing woohoo, woohoo inside too. All right. I was leaking fluid and I am so mad I listened to the doctor about getting induced because I ended up in labor for 48 hours and then an emergency C-section. I was 2 weeks late and I was very young. So yes, these are challenging because remember that the physicians look at an issue, they say, okay, here's what needs to be done about it, and we do it. That's where bringing in a doula or a midwife to listen to those emotional sides, help you create perspective to it, and if you need a medicalized birth, to hopefully be able to retain what things you can retain in that situation. Getting induced because of low water, there are certain things that do have to be monitored, and you learned that firsthand, that these babies, when they're not ready, it is a challenge to go through labor. And they too, especially if there was an epidural on board, we talk about, you know, being able to keep that breathing going so that the baby doesn't get tired. And it can be so frustrating when those things happen. And especially if you go overdue. Going overdue is just a whole nother piece to that puzzle that is a setup for that. So when you get ready to have the next baby, you want to watch my live on inductions and post dates and be able to take those supplements that I've used in our practice that have been super helpful, and understand some of the natural induction ways so that if you ever had to be induced again, that you hopefully have a lot more of your body ready to go and be able to have a good VBAC for you. And I'm so sorry for the emergency cesarean. That is so scary when they do that, when your baby starts having trouble. Hi, what are we talking about? I have lots of questions. Oh, we're talking about too much or too little amniotic fluid and how that is, how it happens, what are the risks, how do we diagnose it, and etc. You're welcome. Any midwives you would recommend in Denver and Castle Rock area? I love your energy and style. Thank you. I appreciate that. I would go on their Colorado Midwives site. I would also look at Midwives Alliance of North America, otherwise known as MANA, and look for the midwives that are there. There is a midwife in Denver who does not practice home birth. Her name is Karen Strange. She does all of our neonatal resuscitation classes all throughout the world. And she may have recommendations for you. But the best thing I would do is look up on those sites and find a few midwives that are there. Ask them questions that you really want to know about how you want your midwifery care to be, and just, you know, write down a few things like that. As well as online, there's a ton of places you can get questions to ask a midwife or a care provider. And when you do, that's a good thing to start with. A midwife should be able to go through almost all of your questions before you even ask them. And then always say, you know, can you tell me if you had to refer out to another midwife, what midwife would you choose? And see if there's anybody within their community that you haven't talked to yet that you might want to. All right. We're going to move on to too much water, and feel free as we come back to stuff to, you know, pop open some questions for me, but let's go to too much water. All right, let's see here. 40-year-old pregnant with my third baby. Surprise! We live 40 minutes from nearest hospital. Not a problem. I really want a home birth. Risky? Nope. If this is a third baby and you live 40 minutes, the general rule of thumb is within an hour of a hospital. That's usually our criteria. We've gone outside of that before, but that's usually the criteria. The one thing I would say, and 40 years old doesn't matter. If you haven't had a baby in 20 years, that could be a little bit different. Your body may be a little more needing its good stretching, which I would definitely look at some of my lives and really get on that birth ball and really keep those hips really fluid. If you've had a baby in the last 10 years, really you're going to do fine. And as far as a home birth, go for it, unless you have other risk factors, obviously. But just to be a third baby in your 40s and 40 minutes from a hospital is nothing I would be concerned about. Okay, so polyhydramnios, too much water. Usually when that happens, your care provider can tell because it's like, where's the baby? They're trying to find the baby in there, and there's so much water that it just feels like there's just a big water balloon. Now it can get to the point that if you were to tap it, you would see it kind of thrill like you threw a rock in water, and it kind of ripples. That is an excess by far. Most birth givers, if they have excess water, if it's building really fast, they will start having a lot of contractions, and there's something that will cause them to want to talk to their care providers. Their care providers, there's a, so one, it's by palpation, two, it's by ultrasound, and let's also look again that we have the fallibility of how well the ultrasound is done. And like I said, don't just discount, oh, well, I'm sure the ultrasound's wrong. Just take it as an FYI and be able to say, all right, you know, what's going on? Now, getting watered down is a little trickier because it's not like you can dehydrate yourself, and you don't want to do that. You could eat some strawberries, some cucumbers, drink some good nettle tea, and just see if maybe you pee off some of that. But generally, if there's more water in there, either there's a bigger baby, sometimes there's two babies, right? And that's normal to have more water when you have two babies in there, for the obvious reason that each baby needs water. The other is gestational diabetes. That is one of the symptoms of gestational diabetes, is having an excessive amount of water, which can mean that the baby is getting affected by those sugar loads and how the insulin is working, and more fluid is built up in there. Again, it can also indicate that the baby has some issue, whether it's a congenital or a genetic issue that's going on. But when there's clinically a lot of water, there's symptoms to that. And when that occurs, then it's again saying, let's keep an eye on it. Usually measurements get big fast. Where did the baby go? There's so much fluid that there's just a lot going on there. You feel like you've grown really fast, which the measurements kind of support that. You might be feeling a lot of preterm type of labor things. That can happen because the uterus says, hey, you're big enough to be term. Let's do something about this because we're growing really fast. And the uterus, by its nature, during birth says we want to empty. Now that's a very non-emotional, sweet way of saying the uterus wants to help you give birth to your baby, but it wants to empty, which is why the placenta comes out, which is why clots come out, which is why it wants to empty. So when it gets big and it gets big fast, it wants to sometimes do that. And there are risk factors to that during labor and during birth. With the placenta, with the baby, the cord, and where the cord is. We don't want the cord coming before the baby, and we don't want the placenta coming with the baby. So there's definitely something that needs to be in a hospital system under surveillance with a high-risk obstetrician to be able to monitor that, because the goal is what? With everybody and everything, what's the goal? A healthy birth giver and a healthy baby, right? That's always what's at the end results here. And that's where with midwifery, again, we deal with normal. When things go out of normal, can we bring them back with the tools that we have available to us between nutrition and nutrition, homeopathy, herbs, acupuncture, various things like that, depending on the time frame of what needs to be done and when to refer out, because the problem is still there. And when the problem is still there, the problem is going to still be there, which means that then it's a higher risk. And that's why with midwifery, you know, when families start with midwifery, they get the best care and they get everything to promote them to have the healthiest, most normal pregnancy possible. When things come up, the goal is recognizing them and helping to transfer care to someone who deals with high risk while supporting the things that are going on and helping that family to understand why those things are beneficial, how those might benefit them, and what other questions they might need to ask. And I think that that's the other side of the advocating for you. It's giving you things to be able to advocate for yourself. And that's what I love about it. You know, it's not because I can't deliver a baby. I'm not delivering babies. You are, right? You're the one that delivers your babies. And being able to have those insights and understanding is really how you can walk your path when something goes outside of normal to advocate for you and the baby. All right, let's see. Other causes that can cause too much water sometimes can be an infection. Again, things can go on with the baby if there's an ABO incompatibility with their blood types and yours. If the baby gets anemic, which is why it's real important for you to keep your iron levels growing good and eating good. Make sure you're eating good proteins and fruits and veggies and keeping your carbs into good carbs that are whole grains. With either one of these, it's very common to have more ultrasounds and what's called a biophysical profile, which means that they look at how much fluid and they look at baby's movements and be able to make sure that everything looks like it's going well, and sometimes a non-stress test as well. And if you haven't had a non-stress test, what that means if they hook you up to monitors is that there's a contraction monitor and a fetal heart monitor. And what they're looking for is the baby to make accelerations and come back down to baseline without making decelerations or going up and getting really tacky and then decelerating. And those are indicators that the baby may or may not be doing well. And so in our office, we do what's called a non-stress test also, but we do it by an auditory. So we listen and we count every 5 seconds for 5 minutes, and we use an auditory to awaken the baby real well, and we listen to the baby get all excited, and we count those heart tones, and we come back down and we look for a baseline, and we're looking again to make sure that the baby doesn't feel stressed or that it doesn't feel out of gas. And those are ways of kind of assessing how the surveillance of the baby is doing. Are they doing well? Whether that's for post dates, water, just a mom that says, I haven't felt the baby as much as I should. Then, you know, you do an NST and see if the baby's happy. And you can always have a biophysical as well, which is an actual ultrasound to look at that. All right, questions. Start firing questions away at me as I sort of finish this up a little bit. So polyhydramnios is considered 25. So when we start looking at these numbers, 2, 3, 5, 8, 25, what do they all mean? Well, 2 is usually the equivalent of about 200 milliliters, which means a little less than a cup. So it's like 3/4 of a cup. A cup would be 240. And so if you get up to 25, that means it's almost 2.5 liters. Okay, so 2.5 quarts of fluid. And that's a lot of fluid. Now, I have had a woman that had polyhydramnios before, and her numbers were 44. So that was a substantial amount of fluid. Now, hers grew gradually. Her baby did not have anything wrong with it per se. It did have some low muscle tone because it was in there, and it didn't have any ability to get push from the uterus to develop its muscle tone quite the way it needed to, but it resolved itself over a year's time. And so low water, high water, the baby needs to be able to grow its muscles, and the baby grows by pushing out against the uterine wall and moving around to develop those muscle tones. So if you get up into that 25, it just means you have a really good amount of water, but that's a borderline on 25, right? That's where it branches into what is clinically known as polyhydramnios. And when you get under 5, you begin to look at oligo, or too little water. But those are what the numbers mean. They want at least 500, which is 2 cups, up to no more than 2.5 liters. Now that's a big span at term. And as you get towards term, like I said, the water level comes down, getting ready for birth. And if you get post-term, some of that starts coming down because the placenta does start getting a little tired. And that's part of why that happens. So knowing your numbers, and you know, the internet is always there for you. You can look anything up, because whether you remember these things, if they should ever come across your path, or a friend or family member has something come across their path, say to them, wow, okay, well, I heard that this and this might be supportive to that, and to make sure that you go back for another scan, because did you know that they can't count the water where there is an umbilical cord in it? Or perhaps there's a lot of water, but now the baby's fluiding it up and it's coming down and it's doing all right. But knowing your numbers, instead of, they just said that I have too much water. Well, what does that mean? It's like saying, oh, well, you have a placenta previa. Well, do I have a placenta previa, or do I have a marginal placenta previa? And if so, how many millimeters is it away from the cervix? And understanding where it can grow to, because placentas always grow up. They don't usually grow down and around. Now they can, but usually they migrate upward as the pregnancy continues. So it's a good thing to ask questions, and a midwife is always somebody that you could go and consult with on a one-time basis. Doulas are great resources as well for educational and emotional support, and to just be a good advocate. All right, any questions coming in? Where are we at on time? 30 something? Oh, good. We have a few minutes to actually do questions. I love it. All right, I know some of you had some questions, so let's see if we can get to them. So start typing away. I think next week, my topic, for those of you who know people, is kind of about what do you do about low milk supply, formula versus donor milk, how to make milk, and etc. So I think that's what we're going to do next week, because there's a lot of, what formula is good, how do we use it, how do you bottle feed, how do you not bottle feed, donor milk, and etc. So that's, I think, what I'm going to do next week. I'm not seeing any questions come in, so there we go. I just joined. I just joined, but how can you increase fluid? Well, one of the main ways is to drink and drink and drink and drink and drink. So you got to drink at least 3 to 4 quarts. So that's almost like a gallon of water for a couple of days. And usually, if you go back, that will usually improve how your water level is. Make sure that you're obviously not taking any herbs or medications that would decrease fluid. Also, make sure you eat really well, lots of protein. And because your placenta depends on you making sure that you eat really well so that it can do its job, so it can support the baby, so that the baby can support itself until it can be born, right? But drinking is the main thing. And that's lots of water. You could do coconut water. I wouldn't think of things like milk, but teas, as long as the teas are not dehydrating. There are some teas that can be that way. I probably would recommend to somebody to get on the dandelion that we recommend because it helps to balance sodium potassium. And I guess there could always be a possibility for somebody that their sodium potassium is not in balance as well, whether they had low water or high water. And to take a couple capsules of that and make sure that they're drinking really well. They're good red raspberry tea, which would nourish their uterus anyway, but lots of fluids, lots of water to help build that amniotic fluid in there. And you will start to notice it because the baby will move around more and you'll start to feel like the baby's moving. You'll feel like your tummy's gotten a little bigger, and it does help. And remember, when we're talking from 1 cup of fluid to 2 cups of fluid, that's not a lot of fluid, right? I mean, if you fill up 2 little measuring cups, right, that's not a huge amount of fluid to, quote unquote, make the scan happy. If it clinically is a reason that the baby needs to be monitored or delivered, that's another story. But to try and solve it first is always a solution, right? I mean, you want to be able to do that because you don't want an induction, you don't want a lot of hooplas if you don't need it. If you need it, great, it's there and you do what it takes to get a healthy baby. All right, thank you so much. Such valuable information. I'm currently at a 9, but I'm trying to turn my breech baby. 34 weeks right now. Should I try to increase fluid to give her room to flip? Absolutely. You know, it does not hurt. 9 is good. And what I would do is I would make sure you keep your fluids really good. Get that 3 quarts a day or 4, but definitely getting that 3 in a day. Keep that fluid really good. I've done a breech live, so there's all of those things that are on there. And you know, the other thing is kind of laying with your hips propped up, laying on your back, prop your hips up on like a few pillows so that you're at an angle to just allow the baby to drop out of the pelvis. And just talk to the baby and imagine the baby head down and be able to say to the baby, I'm so thankful for you. I'm so thankful that you're going to know exactly how to do this, and you're going to spin your little body around so nice and sweetly, get your head down in there so beautifully, and that way we can kind of really go forward with the best birth possible. If that doesn't occur, and some babies kind of get, like I said, stuck that way, having a version at 36 or 37 weeks is a great option. I know that they give you a little bit of worry and concern because they say, well, some of the risks are the placenta could have problems. We may have to take you in for emergency cesarean. Well, not that that isn't true, but truly, if the baby's going to turn, it's going to turn. And you want to have either, if your midwives can or know how to, or they can within their law, if it's a physician, whatever it is number one, make sure there's not a cord someplace that it shouldn't be before a baby is moved. If a baby moves itself, we know it's all fine. But if somebody else goes to forcibly move the baby, it's always a good idea to make sure you know where the cord is first. So then helping a baby to kind of move itself into position saves everybody from having a probable cesarean section in our United States right now. Not that breech vaginal deliveries isn't an option, because it is, but it's harder and harder to find care providers who either who are trained enough in it, or who can attend a breech delivery. So I love what one of my mentors said, just get the baby head down. Don't deal with the breech, get the baby head down. And that's always been our motto too. And they've done really well. And 34 weeks is a great time. You know, if you, the obstetricians won't usually do it until 36. But other care providers sometimes, if that's within their niche, will do it earlier. All right, but yes, a drink. And all right, let's see. My baby's posterior, not the subject of tonight, but quick advice. I've been angling down forward and getting chiropractic care. Great job on the chiropractic. Get yourself a one of the exercise balls, otherwise known as a birth ball. Make sure your hips are higher than your knees, not by a lot, but by some. You don't want to be sitting down into it. You want them higher than your knees, and you want to do big hip circles both ways. Do it morning, noon, and night. all the way around. Loosen up the pelvis, get down on your hands and knees, really move those hips around really good, and just talk to the baby and loosen those things up so that the baby can rotate. Now, if baby is posterior, and most babies, if they were posterior, some of them started out on the right, and they're mobilizing themselves into posterior, which then you hope that they will mobilize themselves to the left. But as long as they get back up front on either the right or the left, either side is great. When you're in labor, if for some reason this baby hasn't completely rotated, stay on your hands and knees. If anything, get your head down, your butt up in the air, and labor like that for an hour, and let the contractions help to rotate the baby into a better position. But those balls do a lot, okay? The other is pulsatilla, which is a homeopathic remedy. P-U-L-I-S, it's very phonetic, pulsatilla. It's very phonetic. But the birth balls, I like those. And talk to the baby. Say, hey, I've got a great birth plan for you. Come on up front. Put your back up front and look towards the back. All right, let's see. Awesome. Thank you so much. Hoping to get my home birth, and I do not want the baby breech. Ha ha ha. Yes. And if you're planning a home birth, you need to get that baby turned. And I don't know if your care provider feels comfortable helping to massage the baby and massage your muscles so that the baby will turn. But there's also chiropractors, like you said, you're going to one that will move babies. Obviously, you can go in for a version with an obstetrician, whatever it is. But yes, get the head down unless everybody's, you know, on board for a vaginal breech delivery. All right, great advice. Thank you. I have a 200C kit as well. Good, great, yes. Pulsatilla, 200C once a day, I'll do it. And let's see. All right, more questions. And you're doing great. There's a new one. Let's see how we doing. All right, so we've got about another 5-6 minutes, and you have one. I love that. Yeah. There are many different types of care providers that will help with breech turning of babies. Sometimes you have to search them out. You have to find the ones that will do that. And you don't want an OBGYN that says, well, I don't think that's a good idea. They don't usually turn. That means that that care provider is not comfortable versioning babies. Find another one, okay? And it's just not that hard. That's what I want you to know. Most babies can be versioned fairly simple in, within about 5 minutes. And then you have a head down baby that you can go forward with your plans. So it's a good idea to sort of get them flipped around. But yes, keep the water good. All right. So week after next, you should see a post that I'm going to put out during the week telling you that I'm ready to get a bunch of questions, and we're going to have a question and answer time again. So start saving up those questions for the week after next, and see what you want to, pick my brain about. Some things I know, some things I don't. We'll figure out what those are, and I'll give you my best. All right, well, if there's no more questions tonight, I'm going to close. I'm going to remind you that you're an amazing person. I may not know you, or some of you I may know. But what I do know is that you're an amazing person, and you have a desire to learn and to take ownership and to become very empowered people. I know that because you're here. So I hope that others will follow you, and that these lives will somehow bless and help you during your path. It may not always solve an issue, but hopefully it gives you ideas and things to start you on a journey that can help you with whatever's on your path, and hopefully to a very smooth, wonderful birth, and breastfeeding the same. But everything happens the way each baby and each birth giver and each individual birth needs to happen. But start out with the bottom, start out with the basics, start out with normal, and work up from there if needed. So go in, hug your children, and if your children are only in your tummy, then hug them in your tummy. Tell them that they're amazing. Tell them that they can do anything that they set their minds to. And I will see you next week, and I hope you'll bring some friends. Okay, bye for now.